So, I think, one thing that I tend to do more robotic cystectomies than open cystectomies kind of in this era. And that's probably, you know, an evolving thing in my practice over the last few years. I imagine it's the same probably for you, Abhinav. But, you know, did you feel that this was any more challenging, or at least the few that you've done? I know this is a multi-institutional cohort, so not all of these patients were yours, but what was your thoughts on post EV pembro? How difficult was the, dissection? Were there any issues in terms of, I guess you had some element of a grade three, about 18%, I think is what your study showed of, Cleveland Dindo complications or higher, but did it feel like it was anything more than what you did in a treatment naive cystectomy?
I think the short answer would be no. Anecdotally talking to, my colleagues and myself who've been doing these cases, there are some cases where you may see a little bit more of sort of an inflammatory rind or inflammatory nature to the tissues. But it's hard to really say that it's categorically different. And I think that's reflected in the data, right? So again, it's a small cohort, but the Clavian 3 or higher complications, 18 to 20%, sort of on par with what you'd expect. At the end of the day, these are cystectomies, right? So
Right.
there's inherently morbidity to that operation. I think we had 29% get readmitted to the hospital, again, on par with most contemporary series of cystectomy, even in the localized setting. And so I don't think, so the data would suggest that these perioperative outcomes in the consolidative setting are pretty similar to what we're
Mhm.
used to. And I think our anecdotal experience intraoperatively would be the same thing. Sometimes, again, this is not supported by anything in our data, but just anecdotally, sometimes you see if patients had nodal metastatic disease and they at the time of diagnosis and they received systemic therapy, sometimes those nodes are a little bit more matted, a little bit more maybe densely adhered to the sidewall or to the pelvic vessels or that sort of thing, but nothing that was really prohibitive.
Sure.
It's not like these cases can't be done or that they're getting aborted or anything like that. These are cystectomies that are still very much, I think, doable. And again, our data would suggest that same thing. So none of the robotic cases had to get converted to open or anything like that.
Sure.
So
And I can only imagine, again, selection bias plays a pretty large part, like you're mentioning, right? If you see a huge bulky tumor invading into the vessels, I'm pretty sure that patient was not going to be even listed on tumor board or whatever it might be to say, let's do consolidative surgery, right? So you're obviously cherry picking of these sick patients overall, probably the healthier versions of those, right? Or healthier types of those patients. I suspect that's probably what kept some of those complication numbers down. But I think that's true for any type of cystectomy patient in general, right? I mean,
right.
it's a tough surgery. Recovery is tough. High rates of readmission and complications. So we try to do our best to select our patients appropriately, which is, I'm sure, what you guys did as well.
Yeah.